Hello everyone. In this class, we'll try to learn how to systematically interpret ECG. The learning objectives would be to interpret normal ECG tracings and their physiological applications, determine the mean QRS axis, and list the common causes of left and right axis deviation. The heart rate includes atrial and ventricular rate. As per at paper speed of 25 millimeters per second, the atrial rate per minute is calculated by dividing 1500 with the pp interval, that is in millimeter. Similarly, ventricular rate per minute is calculated by dividing 1500 with RR interval, that is in millimeters. Normally, RR interval is equal to pp interval, but sometimes ventricular rate may be different from atrial rate. The normal heart rate is 60 to 100 per minute. Usually the heart rate means ventricular rate. Bradycardia is when heart rate decreases less than 60 beats per minute. The causes for bradycardia, sinus bradycardia, which is present in athletes, can be seen in sick sinus syndrome with the drugs like beta blockers, obstructive jaundice, raised intracranial pressure, and in mixed edema. That is hypothyroidism in adults. And also it is seen in junctional rhythm and with the complete heart block. Tachycardia, where heart rate exceeds more than 100 per minute. The sinus tachycardia is seen in anxiety, fever, and hypoxemia, thyrotoxicosis, cardiac failure, and acute carditis. And it is also seen in ectopic tachycardia, that is reentrant tachycardia. It is also seen in atrial premature beats, which can be seen in anxiety, excess tea or coffee intake, or can be in viral infection, rheumatic heart disease because of digitalis toxicity or cardiomyopathies. Tachycardia is also seen in paroxysmal supraventricular tachycardia. It's also seen with atrial fibrillation, where in case of rheumatic heart disease with mitral stenosis, atrial fibrillation is also seen in coronary artery disease, cardiomyopathies, or in thyrotoxicosis. Atrial flutter is seen in rheumatic heart disease or coronary artery disease, and tachycardia is also observed in ventricular premature beats and in ventricular tachycardia. Heart normally beats at a regular intervals, and it is observed by calculating the successive cycle length, that is RR interval. A variation of maximum up to 10% in adjacent cycle length is considered to be normal. Arrhythmia is when abnormalities of cardiac rhythm occurs. Example, physiological arrhythmia is sinus arrhythmia. Waves or intervals. Then the P wave is duration should not exceed more than 0.1 second. The amplitude should not be more than 2.5 millimeters tall. The P wave in lead 1 to AVF and V3 to V6 it is upright. In AVR it is inverted. Lead 3 AVL and V1 V6 it is upright, inverted, or biphasic. The abnormalities of P wave can be due to the atrial enlargement, that is tall and peaked P waves are seen, and in intra-atrial conduction abnormalities. PR interval it measures between 0.1 to 0.2 second. The short PR interval is seen in case of Wolff Parkinson's, that is WPW syndrome, nodal rhythm, atrial premature beats, and long PR interval is seen in first degree AV block, which can occur with rheumatic carditis, digitalis effect, or in coronary artery disease. QRS complex amplitude in limb leads it can exceed 5 mm or more. In the chest lead it can be up to 10 millimeters or more. So duration is not more than 0.11 second. In lead 1, 2 and V4 to V6 R wave is dominant, whereas in AVR, V1 and V2 S wave is dominant. In lead 3 AVL, AVF and V3 either R or S wave may be dominant. The main QRS abnormalities manifest in the amplitude. Low amplitude can be seen in marked emphysema, myxedema, pericardial effusion, or in cardiomyopathy, whereas high amplitude is seen in ventricular hypertrophy. Q wave in lead 1, AVL, V5 and V6, they're small. In AVR, QS complex is commonly found. Lead 3, there can be a deep Q waves in normal individuals and become less prominent on deep inspiration. The depth of Q wave is less than 25% of the height of the ensuing R wave and up to 50% in AVL. Some of the pathological Q waves seen when Q wave is more than 25% of the height of the ensuing R wave or more than 0.4 second in duration is considered pathological. Some of the common causes for these are acute or old myocardial infarction, unstable angina, dilated cardiomyopathy, or hypertrophic cardiomyopathy. ST segment is isoelectric line. ST depression less than 0.5 mm is not abnormal. ST elevation up to 1 mm in limb leads and V5, V6 and 2 mm in V1 to V4 may be normal. ST elevation is commonly seen in acute myocardial infarction and sometimes it is seen in acute pericarditis. ST depression is commonly seen in myocardial ischemia. T wave in lead 1 and lead 2 and V4 to V6 it is upright. In AVR it is inverted. In lead 3, AVL, AVF and V1 to V3 it is upright or it may be inverted or sometimes it can be biphasic. The abnormality is T wave where tall T waves are seen in hyperkalemia and in acute myocardial infarction. Inverted T waves physiologically seen in young children, deep inspiration and after heavy meals sometimes. And pathological inverted T waves are seen in ventricular hypertrophy, bundle branch block or digitalis effect or in case of myocardial ischemia. QT interval should not be more than 0.42 seconds in males and 0.43 seconds in females. QT interval varies with heart rate. Therefore, corrected QTC is measured by using Bezet's formula, where the corrected QTC is equal to QT divided by square root of RR interval. The abnormal QT abnormalities or that is prolonged QT interval is seen in case of congenitally hereditary diseases like the patient who was on antiarrhythmic drugs like quinidine. It is seen in hypokalemia or in acute myocardial infarction. Shortened QT interval is observed in hypercalcemia. Then you have to look for the mean QRS axis. Mean QRS axis is the magnitude and direction of the mean cardiac dipole, that is the mean cardiac vector. Normally this is between minus 30 degree to plus 110 degree. The left axis deviation when the axis falls to the left of minus 30 degree and right axis deviation when axis falls right to the plus 110 degree. The factors that is going to affect the mean cardiac vector are the position of the heart, the properties of the conducting system of the heart, electrical properties of the ventricular myocardium and muscle mass in the each ventricle. Okay, so this is showing the normal vector. Okay, so if it falls between minus 32 plus 110, the mean axis is said to be normal, and if it is beyond minus 30 it is called as left axis deviation, and if it is beyond 110 degree then it is called as right axis deviation. How to measure the QRS axis? The rough estimation is the QRS complexes are studied in lead 1 and AVF. Normally there will be predominantly upright QRS complex in both the leads. In right axis deviation, QRS complex predominantly negative in lead 1, that is there will be dominant S wave, but predominantly positive in AVF, that is there will be dominant R wave. The left axis deviation is when QRS complex predominantly positive in lead 1 but negative in AVF. The intermediate axis is when QRS complexes in both lead 1 and AVF are predominantly negative. Accurately estimated, the QRS axis accurately estimated by two methods, by Enthoven's triangle or hexaxial reference system. Using Enthoven's triangle, the net magnitude of QRS complex of any two of the three standard limbs is measured and plotted on an appropriate axis in Enthoven's triangle. In each lead, distance is equal to the height of R wave minus the height of the largest negative deflection in the QRS complexes are measured. These distances are drawn from the midpoint to the positive or negative side of the triangle representing that particular lead. Then perpendicular lines are drawn from the midpoint of the arms of the triangle to each other. Perpendicular lines are also drawn from the end of the QRS magnitudes drawn on the triangle. An arrow drawn from the center of the triangle to the point of intersection of perpendiculars extended from the distances measured on the sides. This arrow represents the magnitude and the direction of the mean QRS vector. Okay. So these are the points which are drawn from the midline of the limb, okay, and where they are going to intersperse at this particular point, okay, and the cardiac vectors of lead 1, lead 2 and lead 3, okay. So again the point where they are intersecting will be determined, and the axis is drawn from this point to this point, okay. So this will be a mean cardiac axis. Then hexaxial reference system. In this method, the six limb leads are examined to find the one in which the net deflection of QRS complex is close to 0, or R wave has a equal upward or downward deflections. As we know that when cardiac dipole is perpendicular to the particular lead, the net deflection of that lead is 0. Thus it indicates that the mean cardiac vector is perpendicular to that lead in which the net QRS deflection is close to 0. Now hexaxial reference system is plotted and referred to estimate the angle of axis. So some of the abnormal axis deviation, that is right axis deviation, can be seen in right ventricular hypertrophy or left posterior hemiblock, Wolff-Parkinson's syndrome, dextrocardia, and the left axis deviation can be seen in left ventricular hypertrophy, left anterior hemiblock, WPW syndrome, inferior myocardial infarction, or it can be seen in obstructive air diseases. Okay. So this is in brief how to interpret some of the points of ECG. Thank you.